An introduction to an angry organ. Pancreatitis is a medical term that might sound complicated, but it's actually quite straightforward when you break it down. Let's do that together. The suffix, "itis" in medicine simply means inflammation. So pancreatitis literally means inflammation of the pancreas. This isn't just a little bit of irritation, we're talking about a serious and often intensely painful condition. Imagine your pancreas as a highly specialized factory that produces very powerful substances. Normally these substances are kept safely contained until they are needed. But in pancreatitis, something goes wrong with the factory's safety protocols. The powerful digestive juices it creates become activated inside the pancreas itself. This premature activation causes the pancreas to essentially start digesting itself, turning a helpful organ into the source of its own destruction. To truly understand pancreatitis, we first need to appreciate the pancreas itself. Located just behind your stomach, the pancreas is a long, flat gland that plays two major roles in your body. It's a dual-function organ, meaning it's part of both the digestive system and the endocrine system. These two jobs are absolutely essential for your daily survival and well-being. Its first major job is exocrine, which is related to digestion. Your pancreas produces powerful enzymes. Think of them as biological scissors that are crucial for breaking down the food you eat. It secretes enzymes like amylase to break down carbohydrates, lipase to break down fats, and protease to break down proteins. These enzymes are produced in an inactive form and travel through a duct into your small intestine. Only once they are safely inside the intestine do they become activated. The second, equally vital role of the pancreas is endocrine, which involves hormones. Dotted throughout the pancreas are special clusters of cells called the islets of Langerhans. The most famous of these hormones is insulin, which acts like a key, allowing sugar, glucose, from your blood to enter your cells to be used for energy. Another hormone, glucagon, has the opposite effect. It tells your liver to release stored sugar when your blood sugar levels get too low. Together, insulin and glucagon maintain a delicate balance. There are two main culprits that account for the vast majority of acute pancreatitis cases: gallstones and excessive alcohol consumption. Gallstones can travel out of the gallbladder and get stuck in the common bile duct. If a stone blocks this duct, it can prevent pancreatic enzymes from flowing out into the intestine. This backup causes pressure to build inside the pancreas, leading to the premature activation of those digestive enzymes and triggering an attack of pancreatitis. The second major cause is chronic and heavy alcohol use. Alcohol is directly toxic to pancreatic cells and can trigger the premature activation of digestive enzymes within the organ itself. Another very important cause is extremely high levels of triglycerides in the blood. When their levels become excessively high, typically over 1,000 milligrams per deciliter, they can cause pancreatitis. At such high concentrations, these fats get broken down into free fatty acids right inside the blood vessels of the pancreas. These free fatty acids are directly toxic and damaging to pancreatic cells. Other, less common causes include certain medications, abdominal injuries, infections, autoimmune diseases, and genetic factors. In some cases, the cause is never identified. We call that idiopathic pancreatitis. To understand the severity of pancreatitis, we need to look inside the body step by step. It's a cascade. One bad event triggers another, escalating damage. It starts with an initial trigger that breaks a crucial safety mechanism. Inactive digestive enzymes, trypsinogen, are activated to trypsin inside pancreatic cells. This should never happen. Activated trypsin sets off a chain reaction, activating other digestive enzymes, like a spark to a powder keg. A potent cocktail of active enzymes runs loose in the organ. Lipase starts digesting fat cells, fat necrosis. Elastase breaks elastic fibers in vessel walls, causing leaky vessels, bleeding and swelling. This is self-digestion. Tissue injury triggers a massive inflammatory response. The body sends inflammatory cells and chemical messengers called cytokines to the pancreas. The response can spiral out of control. Cytokines can leak into the bloodstream, causing body-wide inflammation and potentially leading to multi-organ crisis. The symptoms of acute pancreatitis are often sudden, severe, and hard to ignore. The most classic symptom is severe, constant, deep pain in the upper abdomen that often radiates straight through to the back. Many describe it as sharp, boring, or piercing. The pain is usually worse after eating, especially fatty meals, and can be slightly relieved by leaning forward or curling into a fetal position. Alongside the intense pain, nausea and vomiting are extremely common. This vomiting can be persistent and often doesn't provide any relief from the pain, which is a key clinical clue. The abdomen may become tender to the touch and appear swollen or distended due to inflammation and fluid buildup. Some people may also develop fever and rapid heart rate. In severe cases, rare but specific signs can appear. Cullen's sign is bruising around the belly button, while Gray-Turner's sign is bruising on the sides of the abdomen, both indicating severe necrotizing pancreatitis. When a patient arrives at the emergency room with severe upper abdominal pain, doctors act like detectives. The diagnostic process relies on three main pillars: clinical presentation, laboratory tests, and imaging studies. Blood testing is crucial. When the pancreas is inflamed, enzymes leak into the bloodstream. We measure amylase and lipase levels. Levels 3 times the upper limit of normal indicate acute pancreatitis. Lipase is more specific to the pancreas, while amylase can be elevated in other conditions. Both tests are useful to confirm clinical suspicion. Additional blood tests help find the cause and assess severity. Liver function tests can point toward gallstones, lipid panels check triglyceride levels, and other markers help predict who may develop severe complications. The third pillar is imaging. Abdominal ultrasound is often first, excellent for detecting gallstones. Contrast-enhanced CT is the gold standard for visualizing the pancreas. CT can clearly show inflammation, fluid collections, and most importantly, detect pancreatic necrosis, critical for guiding treatment in severe cases and determining prognosis.